Hello, dear colleagues. My name is Ghada Sayed Youssef. I am an assistant professor of cardiovascular medicine, Cairo University. I'm going to talk to you today about heart failure with preserved ejection fraction and how is it different from heart failure with reduced ejection fraction. First of all, the definition of heart failure. As you all know, and according to the European Society of Cardiology Heart Failure Guidelines 2016, that heart failure is a clinical syndrome. It's not a disease by itself, it's a syndrome characterized by typical symptoms and signs associated with a structural and/or functional cardiac abnormality, and this abnormality leads to reduced cardiac output and/or elevated intracardiac pressures at rest or during stress. The problem with this definition is that it implies the presence of symptoms and signs of heart failure, while the situation may not be so. So the definition in the American Society of Cardiology of heart failure, they classified heart failure into 4 stages, stage A and B. It implies heart failure without symptoms and signs. Stage A, patients at risk of developing heart failure, and stage B, patients with a structural heart disease without heart failure symptoms, while symptoms and signs start to appear at stages C and D. The European Society guidelines classified heart failure according to the ejection fraction, and they did this classification because heart failure studies showed that patients with reduced ejection fraction had mortality and hospitalization benefits from certain drugs and certain devices. So they classified heart failure according to the ejection fraction into 3 types. Heart failure with reduced ejection fraction, in which the ejection fraction typically less than 40%. Heart failure with preserved ejection fraction, where the ejection fraction must be more than 50%. But because this definition alone is not enough to diagnose heart failure with preserved ejection fraction, they added other parameters to diagnose HFpEF. So patients with ejection fraction more than 50, plus elevated natriuretic peptide, plus objective evidence of structural and/or functional diseases, this makes the diagnosis of HFpEF. And the ejection fraction range in between these conditions, that's ejection fraction between 40 and 49% in association with elevated natriuretic peptide and objective evidence of structural or functional heart diseases. This was classified by the European Society as heart failure with mid-range ejection fraction. In most of heart failure clinical trials with preserved ejection fraction, they included patients with mid-range ejection fraction as well. The prevalence of heart failure with preserved ejection fraction is almost the same as heart failure with reduced ejection fraction. So patients admitted with heart failure, 50% of them will have heart failure with preserved ejection fraction. But the prevalence ranges from 22 to 73% according to age, sex, and the definition applied. So elderly patients, patients above the age of 60 have higher prevalence of heart failure with preserved ejection fraction. Females have higher prevalence of heart failure with preserved ejection fraction. And because of the challenging definition or challenging diagnosis of HFpEF, according to the definition applied, the prevalence changes. As you all know, there are many causes of heart failure with reduced ejection fraction. Actually, it is considered the end stage of any advanced cardiac problems. Patients with heart failure with reduced ejection fraction may have had hypertension, may have had valvular diseases, cardiomyopathy, coronary artery diseases, may have had other lung problems, other medical conditions like anemia, kidney disease, diabetes, obesity. May have had toxic agents like alcohol or chemotherapeutic agents. All these factors may lead to heart failure with reduced ejection fraction. And the diagnosis is straightforward and easy. While patients with heart failure and the preserved ejection fraction having heterogeneous syndrome, these causes or the causes of heart failure with preserved ejection fraction may be cardiac or non-cardiac causes. The cardiac causes may be ventricular dysfunction, diastolic dysfunction as evidenced by echo parameters, and some patients with HFpEF have subtle left ventricular systolic dysfunction, as we will see later. They may have chronotropic incompetence, they may have elevated blood pressure, they may have dynamic mitral regurgitation, lung problem, iron deficiency anemia. These are the non-cardiac causes. may have renal dysfunction, may have obesity, may have depression, and so on. As you can see here, this is the pathophysiology of cardiac systole and diastole in patients with normal heart, in individuals with normal hearts, and in patients with systolic versus diastolic heart failure. As you can see, during diastole, the normal heart relaxes to receive, the normal ventricles relaxes to receive blood from both atria. In patients with systolic heart failure or heart failure with reduced ejection fraction, the ventricles relax, taking into account that the end diastolic pressure is elevated. But in patients with heart failure with preserved ejection fraction, the muscle is thick and stiff, so the relaxation is incomplete, so the amount of blood received from the atria is incomplete. During systole, the normal heart contracts normally and pumps the cardiac output into the great vessels, the aorta and the pulmonary artery. In heart failure with reduced ejection fraction, the ventricular muscle is weak, so the cardiac output is reduced because of the weakness of the ventricular muscle. While in patients with heart failure with preserved ejection fraction, the cardiac muscle works properly, but because the preload or the amount of blood received from the atria during diastole was small, the cardiac output is also small because of the decreased preload. This is the pressure volume curve. The upper panel shows the normal pressure volume curve in patients with heart failure or the resting a pressure volume curve in patient with heart failure with reduced versus heart failure with preserved ejection fraction. As you can see in the purple pressure volume curve, this represents HFpEF, and it shows that the end systolic pressure volume curve is steeper in patient with HFpEF. And this implies that at a certain left ventricular volume, the pressure is higher in patient with HFpEF. The lower panel shows the effect after injecting the patient with vasodilator. In patient with heart failure with reduced ejection fraction, vasodilatation increases the stroke volume with minimal reduction of blood pressure, while in patient with HFpEF, we can see that the blood pressure after injection of vasodilator reduces or lowers markedly, and the stroke volume even decreases. It does not increase on injection of vasodilator. This is a zoom in of the end diastolic volumes and the pressure in patients with heart failure with reduced versus preserved ejection fraction. The upper panel shows that at a certain left ventricular volume, end diastolic volume, the pressure in patient with HFpEF is higher than patient with HFrEF. While at a certain filling pressure, the volume is higher in patient with HFrEF. So simply you can say that patient with HFpEF have their pressure volume curves shifted to the left, while patient with HFrEF have their pressure volume curves shifted to the right. This is a situation at rest and during exercise. We can see that patients with HFpEF have a higher left ventricular end diastolic pressure, as we said before, and this left ventricular end diastolic pressure goes even higher during exercise, and this explains the exercise intolerance in such patients. Also, patients with HFpEF have characteristically chronotropic incompetence, which is a condition defined as failure to reach 70 to 80% of the maximum predicted heart rate during exercise, and it affects about 33 to 77% of patients with HFpEF. This is the typical demographic and comorbidities associated with patients with HFpEF. We can see that patients with advanced age, female gender, patient with hypertension, with kidney disease, metabolic syndrome, obesity, pulmonary diseases, pulmonary hypertension, all these patients are prone to heart failure with preserved ejection fraction. This is a recent systematic review published in the European Journal of Heart Failure 2020, and they explored the literature and saw the recording of comorbidities in studies of heart failure. They included all studies of heart failure, whether with reduced or with preserved ejection fraction, and they even included studies when the ejection fraction was not specified. First observations, they observed that about only 35% of the heart failure trials recorded the presence of comorbidities. And in these trials, they observed that patients with HFrEF have higher incidence of hypertension, and higher incidence of atrial fibrillation, while patients with HFpEF have higher incidence of coronary artery disease, dyslipidemia, chronic kidney disease, and COPD. Now, the diagnosis of heart failure. The European Society of Cardiology proposed an algorithm for diagnosis of patients with suspected heart failure. First of all, clinical assessment, including history of coronary artery disease, history of hypertension, history of cardiac muscle disease, in addition to physical examination for signs of heart failure, in addition to ECG searching for any abnormalities. If all these parameters are normal, then heart failure is unlikely. If more than one of these parameters is present, then we move to the next step, which is assessment of natriuretic peptide level. If the natriuretic peptide levels, either BNP or NT-proBNP, are elevated, then we should opt to do an echocardiography to search for structural and/or functional LV dysfunction. Sometimes we may jump the natriuretic peptide step and go directly from clinical examination to echocardiography. But when comparing heart failure with preserved ejection fraction versus heart failure with reduced ejection fraction, we can find that diagnosis of heart failure with reduced ejection fraction is straightforward. You just find reduced ejection fraction in echocardiography, then the diagnosis is made. While in cases with heart failure with preserved ejection fraction, the diagnosis is more challenging because there are no validated diagnostic criteria of HFpEF. Because of the diagnosis in patients with atrial fibrillation, which is a common association in HFpEF patients, is difficult, and because sometimes patients with HFpEF have normal natriuretic peptide. About 18% of patients with HFpEF have normal natriuretic peptide level, because most of these patients are obese, and in obesity, BNP may not be elevated, and because BNP actually is excreted in response to wall stress, and in patients with HFpEF, the wall stress is not as high as in patients with HFrEF. These are the comparisons in the general characteristics between both conditions. Both conditions are associated with volume overload and the neurohormonal activation. But when observing the echo parameters, we can see by definition that the ejection fraction is lower in patients with HFrEF. The left ventricular wall mass increased in both conditions, but the relative wall thickness is increased in HFpEF and decreased in HFrEF. The end diastolic volume, of course, is higher in HFrEF. The end diastolic pressure and the left atrial size are higher in both conditions. Patients in both conditions have reduced exercise capacity, reduced augmentation of cardiac output, and reduced or increased end diastolic pressure with exercise. As regards the clinical picture, patients with HFpEF have higher incidence of hypertension, while those with HFrEF have higher incidence of coronary artery disease and valvular heart disease. Because of the dilated ventricle, patients with HFrEF have S3, while patients with HFpEF have S4 because of the stiff ventricle. Patients in both conditions may have rales, jugular venous elevation, edema, but the displaced apex is more in patients with HFrEF. As regards the investigations, both conditions may show cardiomegaly, but it's more evident in patients with HFrEF. Both conditions show pulmonary congestion. In the ECG, Q waves are more evident in patients with HFrEF, while left ventricular hypertrophy is more common in patients with HFpEF. The ECG is of poor diagnostic value in patients with HFpEF unless it shows atrial fibrillation or left ventricular hypertrophy, which are common associations in patients with HFpEF. The laboratory workup for HFpEF is similar to that of HFrEF. We do the routine laboratory workup, but we add certain investigations like hemoglobin A1C for diagnosis of diabetes mellitus, ferritin and transferrin saturation for diagnosis of anemia, and TSH for diagnosis of thyroid disease. As regards the role of echocardiography, the European Society of Cardiology Heart Failure Guidelines said that echocardiography is essential for diagnosis of the cause of heart failure and the type of heart failure, because based on the ejection fraction, we can classify heart failure either HFrEF or HFpEF. And we need echocardiography in addition to diagnose the possible etiology and the possible association, valvular diseases, right ventricular function, pulmonary pressure, in addition to the advanced echo technique tissue Doppler evaluation for patients with HFpEF. These are the parameters proposed, the diastolic parameters proposed to diagnose diastolic dysfunction in patient with HFpEF, including the mitral valve inflow patterns, the E velocity, the A velocity, the E over A ratio. In addition to the tissue Doppler parameters, the septal E prime and the lateral E prime and the E to E prime ratios. And these parameters differ according to gender, and it differs according to age. So you can find different parameters and you should interpret your values according to the specific gender and the specific age of the patient. The European Society put certain criteria for diagnosis of HFpEF. They said that if the left atrial volume index is more than 34, if the left ventricular mass index is more than 115 in males and more than 95 in females, if the E to E prime ratio more than 13, and if the mean E prime septal average, septal and the lateral walls less than 9 centimeters, this confirms the diagnosis of HFpEF or increase the probability of diagnosis of HFpEF. In addition, another study showed that patients with HFpEF not just having diastolic dysfunction, but they also may have subtle left ventricular systolic dysfunction. As this study showed that in comparison to control patients and in comparison to patients with hypertension without HFpEF, those with HFpEF have lower global and circumferential strains. And the strains, global and circumferential strains, go lower as the ejection fraction goes lower. This study included patients with ejection fraction 45 to 50, which is typically ejection fraction with mid-range, but they included these patients as part of the heart failure with preserved ejection fraction population. So to summarize this, there is no single echocardiographic parameter sufficient enough to confirm or to exclude the diagnosis of heart failure with preserved ejection fraction. That is why certain protocols or scoring systems have been proposed to diagnose heart failure with preserved ejection fraction. One of them is the Mayo Clinic scoring system. This scoring system depends on clinical and echocardiographic parameters to diagnose or to evaluate the probability of heart failure with preserved ejection fraction. The items included in this scoring system is the weight, the body mass index more than 30, hypertension, and it was diagnosed as the need to use 2 or more antihypertensive medications, the presence of atrial fibrillation, whether paroxysmal or persistent, the presence of pulmonary hypertension diagnosed as pulmonary artery systolic pressure more than 35, age more than 60, and filling pressures, high filling pressure diagnosed as Doppler echocardiographic E to E prime more than 9. Each of these parameters have been assigned certain points, and according to the summation of these points, the level of or the probability of diagnosing heart failure with preserved ejection fraction is evaluated. Another scoring system has been proposed recently in 2019, and this by the Heart Failure Association. It's called the HFpEF scoring system. And it consists of 4 steps. The first step is the initial or pre-test probability of HFpEF. The second step is the diagnostic testing. The third step is the stress parameters or stress test, stress investigations, whether invasive or non-invasive. And step 4 is the step of diagnosing the etiological reason for patients with heart failure with preserved ejection fraction. First step, when you have a breathless patient, you should assess the clinical situation of this patient, symptoms and signs of heart failure. You should ask for natriuretic peptide, ECG, and other investigations, and accordingly, you should calculate the pre-test probability of heart failure with preserved ejection fraction according to the scoring system we are going to see. According to this scoring system, patients are either having low probability of HFpEF, and these patients unlikely to be diagnosed as HFpEF. Patient with high probability of HFpEF, and in these patients HFpEF is confirmed, and we should jump to step 4 and start to investigate the actual etiology of HFpEF. And in some patients the probability is intermediate. There is diagnostic uncertainty for HFpEF. In this patient, we should go to diastolic stress testing, and these stress testing are either non-invasive, and if these are inconclusive, we should go to invasive diagnostic testing. These are the major and the minor criteria for diagnosing or for calculating the probability of HFpEF. They classified these criteria into 4 domains, and in each domain you should take the maximum. So if you have a certain parameter that is major and certain parameters that's minor in the same domain, you take the maximum, which is the major. They assigned 2 points for major criterion, 1 point for minor criterion, and after summation of the score of the 4 domains, they said that if the score is more than or equal 5 points, then the diagnosis of HFpEF is confirmed. If the score is less than or equal 1, then the diagnosis is excluded. It's unlikely for this patient to have HFpEF. And if the scoring system is between 2 and 4, this patient have diagnostic uncertainty about HFpEF, and we should go to diastolic stress testing or invasive hemodynamic measurements to evaluate the presence or the absence of HFpEF. These domains included functional parameters measured by tissue Doppler, like septal and lateral E primes, or average E to E prime ratios, and the tricuspid regurg velocity. The morphological parameters including left atrial volume index and the left ventricular mass index, and which is different in both male and female. And the biomarkers, natriuretic peptides, are classified into biomarkers in patients with sinus rhythm and the biomarkers in patients with atrial fibrillation. And the levels of natriuretic peptides, or the cutoff levels of natriuretic peptides in patients with atrial fibrillation, we can see that it's 3 times higher than patients with sinus rhythm. And finally, we calculate the points assigned to each of these domains, and we go to the algorithm to see the diagnostic probability of HFpEF. As we said, if there is diagnostic uncertainty, we go to step 3, which is advanced workup, echo stress testing. We do stress echo, and we see if the average E to E prime jumped to more than 15, and the tricuspid regurg velocity elevated to more than 3.4 meters per second, then the criterion is fulfilled and the diagnosis of HFpEF is made. While if this criterion is not fulfilled, we should go to invasive hemodynamic measurements. Invasive hemodynamic measurements may be at rest. We calculate or we measure the left ventricular end diastolic pressure or pulmonary capillary wedge pressure. If the end diastolic pressure is more than 16 or the pulmonary capillary wedge pressure is more than 15, then the diagnosis of HFpEF is made. If these criteria is not fulfilled, then we may go to exercise testing using a semi-supine ergometer and calculate or measure the pulmonary capillary wedge pressure. If it goes up to 25 millimeter mercury, then the diagnosis of HFpEF is made. These images show how during exercise the hemodynamics change. On the left panel, we can see here, this is left ventricular graph, pressure graph, and the pulmonary capillary wedge pressure graph. The blue arrow points to the left ventricular end diastolic pressure. The right panel shows these graphs during exercise. After 40 watts exercise, we can see that the left ventricular end diastolic pressure, in addition to the pulmonary capillary wedge pressure, goes up, and this is enough to diagnose heart failure with preserved ejection fraction. After confirming the diagnosis of HFpEF, we need to know the specific etiology. What causes the HFpEF? We have many investigations according to the differential diagnosis we are having in mind. So we should search for amyloidosis, sarcoidosis, Chagas disease, hemochromatosis, and so on. And for each disease, there is specific investigations. So the treatment of heart failure with preserved ejection fraction is quite different from the treatment with heart failure with reduced ejection fraction, because patients with heart failure with reduced ejection fraction have been shown mortality and hospitalization benefits with drugs and with certain devices. On the other hand, patients with HFpEF, they were not shown to have any or very marginal benefit as regards mortality or hospitalization with certain drugs. So the treatment is just symptomatic treatment and risk factors control. This table shows the many studies that have been proposed to investigate the values of different drugs in patients with heart failure's preserved ejection fraction. They tested ACE inhibitors, the ARBs, they tested beta blockers, they tested Ejection, mineralocorticoid receptor antagonists, they tested sacubitril, valsartan. All these drugs did not show, or they showed very minimal or marginal benefit in patients with heart failure with preserved ejection fraction, not enough to be evidenced or to be applied to patients with HFpEF. One of these famous trials is the TopCat trial, which tested the effect of spironolactone in patients with HFpEF versus placebo, and the result was that insignificant reduction in the composite outcome of death, aborted cardiac arrest, and hospitalization for heart failure, and they did not recommend the use of spironolactone in patients with HFpEF. And another trial is a Paragon heart failure trial, which tested the effect of sacubitril, valsartan. We know sacubitril, valsartan have mortality benefit and hospitalization benefit in patients with HFrEF, while in HFpEF it doesn't show this effect. In addition to risk factor controls, we should treat hypertension in patients with HFpEF because treatment of hypertension could prevent or could delay the occurrence of heart failure. Which drug to be used for hypertension in patients with HFpEF? Any drug can be used, but the European Society of Cardiology, they recommend against the use of beta blockers, and there is a single study which showed that olmesartan is not suitable for patients with heart failure with preserved ejection fraction. So these are the drugs that have been used in patients with HFpEF versus patients with HFrEF. As we said, all drugs can be used. Beta blocker is not recommended, and olmesartan should not be used. The optimized heart failure trial said that how low could you go with hypertension in patients with HFpEF? They showed that the lower you go with blood pressure, the poorer outcome. So they recommended against very low reduction of blood pressure in hypertensive patients with HFpEF. This slide summarizes the recommendations proposed by the American versus European Society of Cardiology for patients with heart failure with preserved ejection fraction. As we said, they both recommend diuretics for volume overload management. They both recommend risk factor control, proper risk factor control. They both recommend treatment of hypertension according to guideline-directed medical therapy. The European guidelines recommend anticoagulation for atrial fibrillation, and they recommend metformin for patients with diabetes and HFpEF. As regards the prognosis of heart failure, observational studies showed that patients with HFpEF have similar prognosis than patients with HFrEF. But the clinical studies showed that patients with HFpEF have better outcomes than patients with HFrEF, and that hospitalization in patients with HFpEF is mainly due to non-cardiac causes, while those for patients with HFrEF are mainly due to cardiac causes. This illustration shows that the causes of mortality or the causes of death in patients with HFrEF are mainly due to cardiovascular causes, while in patients with HFpEF are mainly due to non-cardiovascular causes. So to summarize, heart failure with preserved ejection fraction is a common form of heart failure. It is a heterogeneous syndrome with many comorbidities and cardiac and non-cardiac causes. The diagnosis of HFpEF depends on combination of clinical and echocardiographic parameters in addition to natriuretic peptide levels. In contrast to patients with heart failure with reduced ejection fractions, there is no definite mortality benefit in patients with HFpEF with guideline-directed medical therapy, and the prognosis is generally better in patients with HFpEF. Thank you.